Hello, my beautiful classmates. Okay, so this one is on malabsorption syndrome, which I am very familiar with. So, in our book, it's on page 1141, and it's chapter 56, and has actually many causes. Inflammation, intrinsic disease, or injury to the lining of the intestines. Absorption can be affected by any number of things: bile salt deficiency, enzyme deficiency, bacteria, poor circulation, decreased surface area if they've had part of their intestine removed, and then disruption of the mucosal lining. Uh, and it can also be caused by uh, specific things like a decrease in bile salts that affects fat and fat soluble vitamins, decrease in enzymes. One really common one is lactase for people who are lactose intolerant. Also sucrase, maltase, isomaltase, bacterial overgrowth, obstruction to lymphatics leads to a decreased ability to synthesize plasma proteins and minerals, and then decreased blood flow to the intestinal mucosa, i.e., GI surgery. So, or happens during surgery a lot. So, when we assess these patients, symptoms, the classic symptom is going to be chronic diarrhea. Uh, uh, for especially patients who have had like their gallbladder removed, they can have the steatorrhea, the fatty feces, uh, unintentional weight loss, bloating, and flatus, decreased libido, easy bruising, bone pain, anemia, edema. With celiac, malabsorption syndrome is really a big problem. For adults, there's a lot of bloating and weight loss. So, not fun. For malabsorption syndrome, we want to look at serum labs. So they're MCV, MCH, and MCH. Also, normal nutritional panel. So they're calcium, B12, vitamin D, vitamin A, all of those good things. They can also have decreased cholesterol from the ability to process fats. So they can also do an elevated fecal fat analysis, lactose intolerance test, a Schilling test, which is for B12 deficiencies, bile acid breath test, ultrasonography to look for pancreatic tumors, and then also they can do x-rays of the GI tract or CT scans. Our intervention for these patients is going to be to avoid the substances that aggravate malabsorption. So, perfect example is celiac disease. Obviously, the gluten proteins are causing destruction of the jejunum, so we want to tell those patients to maintain a gluten-free diet. Another good example is the patients who have decreased lactase. Obviously, they should be avoiding dairy products or supplement. So patients can take lactase and or drink lactose-free milk, but supplements can be directly related to the vitamin or mineral deficiency. So they can take vitamin B12, they can take their D3, vitamin A, iron, whatever the case may be. They can also take digestive enzymes or drug therapy. For example, there's a drug, I forget the name of it, but there's a drug that patients who have had their gallbladder taken out, they can actually take this drug to help break down fats. So depending on what's causing the malabsorption, we can make sure that they get replacements for those vitamins, minerals, or drugs to help their body break those down. So we also want to do nutrition management. So if they have like cystic fibrosis or gallbladder disease, they should be on a low-fat diet. If they are having malabsorption syndrome from bacterial overgrowth, then they can take antibiotics. And if we want to manage symptoms, we can give them antidiarrheals, anticholinergics, IV fluids. And then there is a chart for this section, chart 56-8, and that is for skincare for patients with chronic diarrhea. It's basically going to be really, really good perineal care with barrier ointments as well. So I think we've all done that in clinical. So that's about it for malabsorption syndrome. It can be pretty serious if they're having broad malabsorption, but yeah, just something that can be a complication with all of these GI disorders. So that's about it. Thanks, guys.